For those of you who just joined, I'm Sue Osthoff with the National Clearinghouse for the Defense of Battered Women, and I really want to welcome all of you, and thank you for joining us. This is the 12th webinar in our series of webinars about survivors who are reentering their communities after jail or prison. And if you missed any of our other webinars in this series, the recordings of the past ones are on our website. Before I go further, I want to just take a second to thank the Office on Violence Against Women and the Family Violence Prevention and Services Program of the U.S. Department of Health and Human Services for the support of this webinar. I mean, we think it's so great that the supporting work focused on survivors who are incarcerated and reentering their communities. And as you have probably noticed, all the participants are muted. And as I mentioned earlier, we will be collecting, I actually didn't mention it earlier, I'm going to mention it now, that we will be collecting questions during the presentation. So down in that chat box that we already talked about, if you have questions, just put them in there and I'll be collecting them. And time allowing, we will ask as many of the questions as we can to the presenters. They're planning to leave about 15 minutes at the end of the presentation for questions. So, as you're probably aware, today's webinar is titled Violence, Trauma, and Reentering Women Living with HIV, Issues to Consider. And in an effort to save time, I put up this slide with their bios on it. So I'm only going to do very brief introductions. I'm sorry the text is a little small there. Their bios are also posted on the Google Drive, and we really hope you'll take some time to look at the bios more closely because they both have very interesting histories, work, and they talk about their passions too. And I think that you really will learn a lot by reading them. I just want to say briefly that it's an honor to get to introduce our speakers today because they're really doing such interesting and important work. And we're really glad that they've agreed to share their wisdom with us today. Elizabeth Long and Teresa Sullivan are the co-coordinators of the Teach Outside program, which is part of the Institute for Community Justice at Philadelphia Fight, which is an amazing health services organization here in Philadelphia. And they provide services and advocacy for people living with HIV/AIDS and to those at high risk. And they'll talk about it more. And I just think that it's so wonderful that this Institute for Community Justice, where they work, they really have this commitment to working to reduce not only the number of people in prison living with HIV, but also to address the lasting effects of mass imprisonment on communities who are most affected. Now, how cool is that? I just think it's a great mission. And like I said, they'll be talking more about their program and where they work and the work that they're doing, providing education for people living with HIV/AIDS who have been in prison or jail. And in addition to what you can read here about our presenters here on the slide, not only was Teresa honored this year as an outstanding leader in her community from the International Women's Leadership Association, she also received a grant from the AIDS United for the Positive Organizing Project, which is a Philadelphia Regional Chapter Positive Women's Network. Katita, I think we have the link there, so you can learn a little bit more about that. So congratulations, Teresa, for those two honors. So we're very pleased to have them as our presenters today and know they have a lot to share, so I'm going to move on. If you have any questions, please type them in the chat box in the lower left-hand corner of your screen. If you are listening in only and have questions, please email dot@ncdbw.org. Just put your questions down in the corner and I'll acknowledge it, that I see it, and then we'll ask the questions at the end. So thank you so much, Elizabeth and Teresa, for all your great work, and thank you for your willingness to share it with all of us today. So I'm going to turn it over to you. Thank you so much.
All right. Thank you, Sue. Before we get started on talking about what we're talking about in the webinar, I want to tell you a little bit about the work that we do at the Institute for Community Justice. The Institute for Community Justice was founded as a part of Philadelphia Fight's commitment to working to reduce not only the number of people in prison living with HIV, but also the lasting effects of mass imprisonment on communities most affected. Our mission is to create a stigma-free space with innovative prevention-focused programs that empower, educate, and support people affected by the parallel crises of HIV and mass imprisonment, and to protect community health and raise consciousness around issues of social justice. We have a drop-in center with skills building and educational programs focused on continuing education, digital literacy, leadership development, and community organizing in art and creative expression. We also offer prison linkage services to individuals living with HIV who are imprisoned within the Philadelphia prison system. Linkage specialists are available for advocacy, support, education, and linkages to medical care and supportive services when folks are released. Another thing we do is Teach Outside, which is the program that Teresa and I coordinate. And Teresa's going to tell you a little bit about the history of that.
So a little history about how TEACH programs came into existence. The TEACH programs began at ACT UP Philadelphia, that's located here, from activists, advocates, people living with HIV in the early 90s. They wanted to empower people living with HIV HIV education, self-advocacy, and make sure that people are put into leadership roles so they can be at the decision-making tables when things are being discussed about what is going to happen in policy for people who are living with HIV. And also to make sure that what they decide in policy fits the reality of the lived experience of people living with HIV. So we make sure that people living with HIV are also at that table when something is being decided on the policy level that affects their lives.
Right. So TEACH stands for Treatment, Education, Activists Combating HIV, and it's a 5-week educational and activist training course for people living with HIV who have experienced incarceration. Teresa and I are also on a team of folks that publish Prison Health News, a free quarterly newsletter for people who are currently incarcerated that publishes health information, especially that focused on HIV and the activism to address health injustices inside prisons. Most of our articles are written by individuals who are currently incarcerated, and currently we have over 3,000 incarcerated subscribers, and another 2,000 plus copies of each issue go to different kinds of books through bars, programs, prison libraries, and community organizations. You can find a PDF of our latest issue of Prison Health News in the Google handout. Our objectives for today are to identify how violence, especially intimate partner violence, and trauma increase a woman's susceptibility of acquiring HIV, increase the likelihood of HIV treatment failure, and decrease women's ability to more safely negotiate safer sex and/or drug use practices. We'll be recognizing the overlap of risk factors between high risk of HIV as well as incarceration or involvement with the criminal legal system. And we'll talk about the various basic needs that advocates should be aware of when working with returning survivors who have HIV. We'll also talk about the importance of initiating and strengthening collaborations with local services, including anti-domestic violence and sexual assault organizations, and organizations that work with people living with HIV. But before we get started, I want to talk a little bit on the language that we'll be using. So when we're talking about survivors, we're referring to a person who experiences a pattern of power and control. And surviving is all the ways that women resist, including ways that are criminalized. We call women engaged in this process survivors, even if and when the criminal legal system may classify them as offenders or perpetrators. We say abusers or abusive partners to refer to a person who is establishing a pattern of power and control over an intimate partner. When Teresa and I are talking about women, we're referring to all women, not just cisgender women. And cisgender women refers to women who are assigned female at birth and also identify as women. So when we're referring to women, we're talking about cisgender women, but we're also talking about transgender and gender nonconforming women. That being said, we reference an array of sources in this presentation, many of which do not use the term women inclusively. So be aware of that and know that due to the violence of transphobia and transmisogyny, trans women are at an increased risk of the violence that cisgender women experience, as well as transphobic motivated violence. And then when we're talking about involvement in the criminal legal system and incarceration, We're not going to say criminal justice system because we know that that system is not a place where survivors living with HIV experience very much justice. We'll say criminal legal system, and then we often choose to use imprisonment instead of incarceration because the word is more clear about the reality of incarceration, that people are being held in captivity.
So we have a destigmatizing language model that we want people to use when addressing people living with HIV. We want to have people language before the status model. What we want to do is make sure that you say people living with HIV, women living with HIV, putting the person first before the status. Because that, when they seek services, removes the stigmatizing language that will keep them engaged in service and health care. And if you recognize and treat them with dignity and respect, and acknowledge that they are a person or a woman living with HIV first and foremost. There's no such thing as full-blown AIDS. That was a media hype that came out of the media back in the early part of the epidemic in the early 80s. What we want to do when we talk about non-stigmatizing language is change those languages that are stigmatizing and keeping people from linking to care or even getting tested by saying AIDS diagnosis, a person living with an AIDS diagnosis. Stigmatizing HIV language increases the possibility for so many women reentering back into the community not to seek treatment, not to engage in care, and not to stay in care after incarceration. Women living with HIV that are reentering are already dealing with the stresses of rebuilding their lives when coming home to the community after being incarcerated. Stigmatizing against them once they're back in the community and not treating them with dignity and respect in healthcare settings or within our own society is one more stressor that only will increase the chances of most of women not reaching viral suppression. And that is our goal. Achieving the best health outcomes for positive women requires healthcare settings that are non-stigmatizing and using non-stigmatizing language, holistic and integrating gender sensitivity for women and upholding positive women's rights and dignity. We wanted it to be peer-based and culturally relevant to fit the reality of all women living with HIV.
Before we get into the specifics of violence against formerly incarcerated women living with HIV, we want to touch on some of the philosophies that inform and inspire our position, analysis, and recommendation. And those include harm reduction, a survivor-centric focus, being trauma-informed, and an anti-oppression framework. So just a little bit that we have heard about what harm reduction means in different avenues. But I want to talk about harm reduction theory in a service delivery model, effective public health strategy, and it's a social justice and human rights movement when we're talking about reentry for women living with HIV. Harm reduction is a non-judgmental model and meeting people where they're at in the process of treatment decision-making. Harm reduction began to discuss frequently after the threat of HIV and being spread by intravenous drug users was first recognized. However, similar approaches have long been used in many other contexts for a wide range of risky behaviors that make women more vulnerable to HIV and more vulnerable to sexual transmitted illnesses. So we want to think about it in those terms when we talk about harm reduction. And that's what we do in our program and over here at our Institute for Community Justice and Teach Outside. We meet people where they're at, and we use a harm reduction model to make sure that we engage people in care and keep them in care. We work from a survivor-centered perspective because we understand self-determination as a precondition for safety, not the other way around. The very nature of intimate partner violence, as well as incarceration, is taking control over another person's life, thereby undermining women's ability to be self-determining. Safety can only exist as a product of being in charge of oneself. imprisonment, and intimate partner violence attempt to strip survivors and incarcerated women's subjectivity away and turn them into objects that are only acted upon. It's imperative that we disrupt those dynamics by supporting the wishes, decisions, choices, knowledge, and experience of survivors. We do this by sharing information and helping survivors build skills, while simultaneously working to address the institutional and structural barriers that undermine women's abilities to be in charge of their lives.
So we want to talk about also trauma-informed care and organization structures and treatment framework that involves understanding of service providers or anyone working in the field providing for women living with HIV reentering back into the community. Culture-sensitive trauma-informed care refers to the capacity for healthcare providers to be more effective providing trauma-informed assessments and interventions that acknowledge respect, integrating patients and their families and cultural values, beliefs, and practices when they're talking about providing trauma-informed centered care for women living with HIV.
When we're talking about oppression, we're talking about prejudice and power, not just bias, but the institutional power that backs it up. And I think it's helpful to think about oppression playing out in 4 I's: ideological, institutional, interpersonal, and internal. And we'll talk a little bit more about those later as they relate to the intersection of incarceration and HIV. But why is this important when addressing intimate partner violence for formerly incarcerated women living with HIV? Because when we're talking about women in reentry, we have to talk about oppression, because prisons are state apparatuses of racism. The criminal legal system in the United States targets, criminalizes, and imprisons disproportionate numbers of people of color. Too often, the focus is on the men impacted by the system, and the experiences of women of color are invisibilized. Black women are imprisoned at 3 times the rate of white women, and when it comes to HIV, Black women also bear the greatest burden. Latinos are also disproportionately affected. Of new infections in 2010, 64% occurred in Blacks, 18% were in whites, and 15% were in Latinas. Compared to white women, Black women were 20 times more likely, and Latinas were 4 times more likely to newly acquire HIV. HIV doesn't discriminate, but the social and political conditions that shape who is most vulnerable to acquiring HIV are rife with discrimination and oppression. When confronting violence against women and supporting survivors, understanding and actively disrupting oppression is necessary because abusive partners rely on inequality and systems of oppression to establish and maintain abusive control. Understanding racism and the disproportionate impact of criminalization on people of color, especially queer and trans women of color, is essential to everything from safety planning to policy change. Finally, we use an anti-oppression framework intersectionally, meaning that when we're talking about oppression, we are working to recognize the ways in which systems of oppression and domination overlap and intersect. Therefore, when talking about issues to consider when it comes to supporting formerly incarcerated survivors living with HIV, we have to be talking about the ways in which racism, sexism, transmisogyny, and economic inequality and exploitation overlap in the lives of those most affected by HIV and imprisonment: women of color, especially poor and trans women of color.
So we also want to just give you a brief synopsis on HIV 101. HIV is only transmitted through 4 blood-on-body fluids, and that's semen, blood, semen, vaginal fluid, and breast milk. HIV affects the CD4 cell, the immune system cell, and HIV diagnosis is not the same. You can have HIV, but you don't necessarily have to progress to having an AIDS diagnosis. As you notice that I'm using the terms that are non-stigmatizing. It is unacceptable that more than 30 years and loads of research and lived experience into the HIV epidemic, we continue to encounter and fight the same myths, misinformation about HIV in our newspapers, on TV, as well as in our daily lives. One key factor I want you to remember is that the fluids that are capable of containing high concentrations of the virus is blood, semen, vaginal fluids, rectal secretions, and breast milk must come directly in contact with a mucous membrane or damaged tissue or be directly injected into the bloodstream for transmission to be possible. HIV transmission is not possible under any other circumstances, and people need to understand that. You cannot contract HIV through hugs, handshakes, toilet seats, sharing a cup, or eating food cooked by a person living with HIV. The fact that these myths are still in the general population is damaging to the well-being of women living with HIV and shows how great the need is for reporting accurate information on the transmission of HIV. These are the facts, and there are fictions we want the women living with HIV reentering back into the community to have. Actual facts, not misinformation on HIV. So they're more able to have healthier and longer productive lives. More importantly, increase the prevalence of women living with HIV to reach viral suppression. It's vital for everyone supporting women living with HIV to be well informed on HIV one-on-one basis to be more effective in supporting those that they serve that are living with HIV, facing intimate partner violence, and are also reentering back into the community.
As expressed earlier, one way of thinking about oppression is looking at the 4 I's: ideological, institutional, interpersonal, and internalized. We know that HIV and incarceration overlap. 1 in 7 people with HIV will pass through our prisons and jails this year. And when we look at what communities have been the hardest hit by both HIV and incarceration, we see that Black communities have been the hardest hit. So when we are talking about the experiences of women doubly hit by the epidemics of HIV and mass imprisonment, we are often talking about Black women and therefore need to be talking about the intersection of racism and sexism, which oft includes the overlap of classism and transphobia. Breaking it down into the 4 I's of oppression is one way to organize the violence and oppression experienced by women impacted by HIV and incarceration. So we're going to talk about kind of what that looks like for each of those. When we're talking about ideological oppression, we're talking about the stories we tell about who deserves power, resources, and safety in our society. This impacts women living with HIV who have experienced incarceration through stigma. The ideas about people living with HIV as dangerous that contributes to their criminalization, or racist ideologies that frame Black people as criminal. Additionally, all of the ways in which misinformation about HIV helps spread stigma. That's why it's so important that advocates know their HIV 101 so they're not spreading this stigma. Institutionally, oppression is played out. It's demonstrated in how institutions and systems reinforce and manifest that ideology.
So we need to recognize that HIV is a system of a larger problem. What is being said in an ideal world where there's no racism, classism, homophobia, poverty, lack of health care, homelessness, inclusion of women in mass incarceration, war on drugs, defunding substance abuse, mental health programs, unemployment, and abstinence-only education are the root cause analysis that make women vulnerable to HIV in the first place. And HIV criminal laws are based on long, outdated, inaccurate beliefs that the roots and risks of HIV transmission. Such laws only perpetrate and misguide people about the risk for HIV transmission, increasing stigma against women living with HIV and all people living with HIV in our community.
Additionally, we see institutional oppression at the intersection of HIV and incarceration play out, for example, in the healthcare system, where a lack of intimate partner violence and trauma screening and failures to link women living with HIV and reentry to HIV treatment on the outside. In domestic violence shelters, this can include not having policies in place that protect the confidentiality of women living with HIV, as well as policies that exclude trans women from services. We know that HIV is transmitted through behaviors, but people are more likely to get HIV because of the ways that institutional oppression plays out through government policies and the ways in which prisons work. Prisons disrupt family and social networks and weaken emotional, financial, and political support systems in communities outside of prison. Additionally, the criminalization of HIV, which Teresa talked about briefly, attempts to control the sexuality and reproduction of women living with HIV. For example, by shaming women living with HIV about sexuality or parenthood desires. These are forms of structural violence against women living with HIV and can lead to increased intimate partner violence. Interpersonally, oppression plays out in the way that we play violence out on each other based on that oppression. We're going to talk a lot more about that when we're talking about the dynamics of intimate partner violence for women living with HIV, but one example is the way in which HIV status is used as justification for violence and abuse, and blame and punishment. Internalized oppression is how we internalize the ideological ideas of oppression. And for women living with HIV who have experienced incarceration, they can internalize ideologies of inferiority, see it reflected in institutions, experience mistreatment and violence interpersonally, and eventually come to internalize these negative messages about themselves.
So what we want to talk more about is because of the social and economic inequalities for women living with HIV, they shouldn't take on the entire blame of contracting HIV in the first place. What we see is HIV. What is hidden is the root cause of acquiring HIV in the first place, like poverty, disfunding of substance abuse, like I spoke about earlier, lack of mental health interventions for women coming home, programs and unemployment for women into the community after being incarcerated. But we also know that internalized stigma for women living with HIV, it becomes a barrier for them to link to care because they are self-blaming themselves for contracting HIV in the first place, or even engaging in a healthy relationship, and knowing that they have self-worth and it is a human rights framework to think in the terms that they should have the right to have a healthy sexual life without any being harmed or by any kind of partner or even by their society in a whole. What we need to do is remove and deal with the internal stigma with women living with HIV, and then further deal with the external stigma that's within inside of our community if we're able to develop a model that will make women more safer in the communities and empower them to have long and healthy, livable lives and take care of themselves when they get home in the community. That's vital for what we're talking about in this presentation.
Yeah, so we talk about the 4 I's of oppression at the intersection of HIV and incarceration because we think it's especially important to recognize all 4 of those ways that oppression plays out. And in order to be eliminating oppression, building safety, supporting the self-determination of survivors, and ending systems of oppression, we have to target it at all of those different levels. Now I want to talk a little bit about the overlap of risk for incarceration and HIV. For girls and women, there's significant overlap in the risks for experiencing incarceration and acquiring HIV. For example, sexual abuse in childhood and forced sexual initiation in adolescence are associated with behaviors that carry high HIV risk, including sex with multiple partners, sex with unfamiliar and older partners, sex under the influence of alcohol, anal sex, and low rates of condom use. A majority of imprisoned women report experiencing sexual or physical abuse before their incarceration as well. And the Department of Justice has found that child abuse and neglect increases the likelihood of being arrested for a violent crime by 30%. So violence and trauma obviously have a huge impact on women's risk of acquiring HIV or experiencing incarceration. And many girls and women are experiencing abuse and violence at home, in their communities, and in the ways in which racism, sexism, heterosexism, and transphobia impact their lives. And then our current criminal legal system then criminalizes them and punishes them for a lot of the behaviors they exhibit in response to the trauma and violence that they've experienced. In thinking about the criminalization of sex work as an overlapping risk factor, we need to think about how survivors of intimate partner violence are more likely than women who have not experienced intimate partner violence to report behaviors that are criminalized and known to increase the risk of HIV. So including injection drug use and giving or receiving money or drugs for sex. So by themselves, injection drug use and receiving money or drugs for sex carries a risk of HIV transmission, and criminalization increases that risk. For example, policies that allow possession of condoms as evidence to support prostitution-related charges put women involved in the sex trade in positions in which they must choose between increased risk of police harassment and arrest if they're carrying condoms, or increased risk of HIV transmission if they choose to not carry condoms. Additionally, the criminalization of sex work is one more thing that abusers can use to control their partners, from fear of arrest to incarceration and losing custody of their children. Women doing sex work may also fear accessing social services where they can't disclose about it, and criminalization increases the risk of sexual assault, which of course increases the risk of HIV transmission through sex. Mass imprisonment tied to the war on drugs tears families and communities apart, weakening the support system that help keep women and everyone safe. And it increases the likelihood that women will be criminalized instead of receiving treatment and care for drug use. Black women are much more likely to be arrested for drug possession or sales than white women, even though they use drugs at the same rate. And under the war on drugs, politicians in the late 1970s began pushing imprisonment over drug treatment. These laws were designed to restrict people's rights once they are released. These policies exclude people from jobs, housing, and participation in society, thereby increasing women's isolation and vulnerability to intimate partner violence, as well as the behaviors that carry high risks of HIV. I want to quote one of the founders of the Teach Outside program, Laura McTighe, in a recent article in Prison Health News in which she said, "The war on drugs has been a war on relationships. It's a war on people's parents, their spouses, their partners, and their caretakers. These are the relationships that hold together strong and vibrant communities. These are the relationships people depend on for support in times of need. In the wake of a partner's imprisonment, a mother may suddenly be saddled with the impossible burden of making ends meet to keep a roof over her children's head and food in their bellies. If sex work is her only source of income, she is going to do what she has to do to take care of her children. Sex work will put her at risk for HIV, but long-term health consequences like HIV might not even register in her mind because she's dealing with a pressing crisis." More and more people have been put in positions of making such impossible decisions, especially women. And because of the racism of the war on drugs, HIV has most impacted communities of color, particularly Black communities. That's why mass imprisonment is a major reason for the disproportionate impact of HIV on Black communities. And this is one of the ways in which the war on drugs lies at the gendered intersection of violence against women, HIV, and incarceration.
So what do we know about women with HIV and intimate partner violence? over half of women living with HIV have experienced some form of intimate partner violence, and women living with HIV experience that 55% more than women who are not positive. There are roughly 300,000 women living with HIV in the United States. Women living with HIV are 4 times more likely to have post-traumatic stress disorders and twice likely to have been the victims of intimate partner violence compared to the national samples of the American women, according to the UCSF analysis. Studies analysis have revealed that women living with HIV have between 2 and 6 times higher rates of various types of child and adult sexual and physical abuse. Evidence of the link between violence and increases vulnerability to HIV in the first place. Let's talk about treatment failure for women living with HIV who are dealing with intimate partner violence. Women who have experienced recent trauma are over 4 times more likely to fail their HIV treatment and almost 4 times more likely to be unable to negotiate or engage in safe sex and drug use practices. That is one of the long cohort studies that women on HIV studies, that HIV-positive women who reported abuse within the 30 days were 42% as likely to die as women who did not report abuse within in the past 30 days.
So this is a power and control wheel adapted for people at risk of or living with HIV by the Alabama Coalition Against Domestic Violence and Montgomery AIDS Outreach, and reprinted in the National Network to End Domestic Violence's DV and HIV/AIDS Toolkit, which is listed in the resources at the end of this webinar, and I highly recommend people check it out. It has a lot of resources. This shows how the intersection of HIV and DV changes the tactics used by abusive partners to gain power and control over an individual when either one or both partners have HIV. And I apologize, it's so hard to read. You can actually read it on their handout, so definitely check that out. Excuse me, I've got a cough. One thing I want to add to this is that for all women living with HIV, but especially for women who've experienced incarceration, and especially those currently under state surveillance through parole or probation, we also need to think about HIV criminalization laws and how those can be used as a tool of power and control by abusive partners. A little bit about HIV criminalization laws. HIV criminalization laws criminalize HIV exposure and transmission through consensual sex, needle sharing, or through spitting and biting, despite the fact that spitting and biting do not transmit HIV. I'm sorry. A majority of these laws do not require proving the intent to transmit HIV. Most laws only require that the person knew her or his HIV status for a successful prosecution. This effectively penalizes an HIV-positive person for knowing their status and results in a he said, she said, or she said battle, where the person who knows their HIV status usually loses. This is especially important to think about because women are often the first person in the relationship to know their status. And so this puts them at an increased risk of arrest just for being informed. HIV criminalization laws discourage testing and treatment, and they don't protect women. In fact, many women have been sent to prison under these laws, often by partners who knew the woman's HIV status, but used the laws as a tool of abuse, coercion, or harassment when the woman attempted to end the relationship. This is especially important to think about when working with a client who is living with HIV and you're talking about the disclosure of her status. But before we get to that, I want to talk a bit about how intimate partner violence increases women's susceptibility of acquiring HIV and special considerations for women who have experienced incarceration.
So I also want to just add one small quote before Elizabeth continues on. for the Positive Women's Network of the United States of America. And they quote, "Intimate partner violence is all about power and control. And wraparound supportive services include emotional support for women with HIV that experience intimate partner violence. What is needed is peer-based service, case management, transportation, stable housing. Child care services is vital to women who have leaving intimate partner violence relationships, mental health services, substance use services, employment services, and legal assistance. Food vouchers are essential to meet the needs of women living with HIV. When these supportive services are absent from women that experience intimate partner violence, HIV-positive women are likely to stay in an abusive relationship and have high treatment failure than women that have never experienced intimate partner violence."
So how does intimate partner violence increase women's susceptibility of acquiring HIV? Well, in many cases, the factors that put women at risk for acquiring HIV are similar to those that make them vulnerable to experiencing trauma and intimate partner violence. Women in violent relationships are at a 4 times greater risk for contracting STIs, including HIV, than women in nonviolent relationships. And women who experience intimate partner violence are more likely to report risk factors for HIV. Sexual assault in a relationship rarely exists in a vacuum. It often occurs alongside other forms of abusive behavior. The majority of women who are physically assaulted by an intimate partner had been sexually assaulted by that same partner. In relationships where abuse and power imbalances are present, women often have little control over sexual and condom negotiation. I'm so sorry, y'all. I'm really having a tickle in my throat. Some cannot safely say no to having sex or doing other things their partner wants them to do. This, of course, limits their ability to reduce their own risk for HIV from sexual transmission. Coercive condom dynamics and fear of negotiation are common for those in abusive relationships. For example, girls who experience dating violence were 3 times more likely to fear the perceived consequences of negotiating condom use than non-abused girls. And they were over 5 times as likely to report experiencing negative consequences of condom requests. So girls and women in abusive relationships often know that if they work to protect themselves from acquiring HIV, they will experience greater negative consequences and violence. So that's what they're grappling with. Additionally, women who've experienced incarceration have higher rates of substance use and addiction. For those women, even if they are in recovery, abusive partners may take advantage of that vulnerability and attempt to get the survivor to start using again. If the survivor in reentry starts using again, she's at risk of going back to prison or jail, as well as at increased risk of HIV for a couple of reasons. 1, sharing needles, drug preparation equipment, or works, but also because when folks are under the influence of drugs or alcohol, their inhibitions are lowered, creating risk factors for HIV transmission by encouraging high-risk sexual behavior. As I mentioned earlier, women with a history of intimate partner violence victimization are more likely than those who do not to report behaviors known to increase the risk of HIV, including injection drug use, giving or receiving money or drugs for sex, treatment for a sexually transmitted infection, and anal sex without a condom in the last year. It's imperative that advocates discuss sex and sexuality in the context of safety planning with all survivors. Incorporate discussions of risk reduction in individual counseling, support groups, and other supportive environments with all survivors. Risk reduction involves helping clients choose an option that's less risky. For example, is it possible to negotiate giving oral sex instead of engaging in anal or vaginal sex? If not, can the woman use an insertive condom? Obviously, these are options that can be provided. Risk reduction when centering the survivor means providing options that she can choose from. She is the best expert on what risk she's taking when attempting to negotiate risk reduction with an abusive partner. She should never be pressured or told that she should be doing one thing or another to reduce the risk of HIV transmission.
So what we also have is a amazing new drug called PrEP, pre-exposure prophylaxis. HIV negative people can take medications daily in order to reduce the risk of HIV transmission. Pre-exposure prophylaxis, PrEP for short, is an HIV prevention strategy where HIV negative individual takes an anti-HIV medication called Truvada to reduce the risk of acquiring HIV. The medication works to prevent HIV from establishing inside the body, and PrEP has been shown to reduce the risk of acquiring HIV through sex with gay, bisexual men, transgender women and men, heterosexual men and women, as well as people who inject intravenous users. It does not prevent against other sexually transmitted diseases, and it does not prevent pregnancy. Truvada is the first FDA-approved drug that HIV-negative people can take to prevent acquiring HIV. It is effective by 90% with good adherence to the medication. When women live with HIV are in intimate partner relationships and cannot negotiate condom use, PrEP becomes a prevention justice tool that they can use to prevent acquiring HIV from the abusive partner. It is vital that women have these tools in their toolbox, that they don't have to have consent from the abusive partners, especially if they're being in an intimate partner violence relationship. And I'm excited, and I hope you're excited, that there's a lot of more prevention justice tools for women in studies and in research, and will be coming out to the marketplace and be accessible for women in maybe a couple of years from now. So I hope you're excited about that as much as I am. Intimate partner violence increases the likelihood of HIV treatment failure. Treatment failure. Women with HIV who experience intimate partner violence over 4 times more likely to fail the HIV treatment, and almost 4 times more likely to be unable to negotiate or engage in safe sex and drugs using practices. That I said earlier, and this is also another reason why we have PrEP, Truvada, for women who are in intimate partner violence and cannot negotiate any kind of condom use and need the consent of her abuser to use any kind of form of condoms without being abused. The stresses of reentering back into the community for a lot of women with HIV, it's traumatizing, and resources and programs to link women living with HIV to healthcare settings that must be well informed on trauma-informed care practices, and is a central component to consider for women living with HIV. In today's world, it's unacceptable that in the United States today, violence and trauma continues to increase a woman's susceptibility to acquire HIV. Violence and trauma leads to poor health outcomes, including death for women living with HIV, and that violence and trauma is wide gender inequalities, especially for women of color, young women, women who are poor, and transgender women. There is a great need for trauma-informed care and healthcare studies for women reentering back into the community from incarceration. Intimate partner violence is about power and control over an individual, and for women living with HIV, the stress of being in an intimate partner relationship that is emotional, mental, and physical abusive can lead to treatment failure to the ARV's regimens. Screening for trauma and intimate partner violence needs to be implemented into women-centered healthcare settings, and also providers need to be trained to identify intimate partner violence is crucial to treat the trauma in the lives of women living with HIV.
The presence of violence in a relationship may make it difficult for someone to get tested for HIV, to disclose their results, or to access health care or supportive services. Therefore, it's very important that intimate partner violence advocates are very comfortable in discussing sexual behavior and history, sexual violence, and the risks for HIV acquisition, and risk reduction as a part of safety planning. Each situation is different, and each provider needs to decide when is the appropriate time to discuss this. Opportunities to open this discussion, though, include when drug use or sexual violence is disclosed. But again, you could also just start by bringing up that part of your procedure is to talk to every survivor about HIV testing. Some things to listen for in such a conversation include multiple partners, an abusive partner who has multiple partners, and/or anal or vaginal sex without a condom. You can talk about HIV during the first meeting with a survivor, when discussing sexual history, and/or when safety planning. Some things to ask can include, are you afraid of your partner's reaction to talking about HIV testing, about your partner acquiring HIV? Do you and your partner practice safer sex? Are you afraid to ask your partner to use barriers? Does your partner force or coerce you into having unprotected sex with them or with other people? Does your partner have unprotected sex with other people? When a woman discloses her HIV status, remind her that you will keep that information confidential, and ask her if she would like referrals for services. It's illegal to share someone's HIV status with a third party. Make sure you take the steps to prevent the inadvertent disclosure of a survivor status to other service participants or staff.
So helpful practices that we want to talk about that can be implemented into service providers' toolbox, and also want helpful practices that women living with HIV can use. There are in intimate partner violence relationships, reentering back into the community. It is crucial as service providers for women living with HIV. Engagement treatment are treated with dignity, respect, empower women living with HIV with accurate HIV facts through HIV educational programs, interventions for intimate partner violence, and economic justice is necessary to address the HIV epidemic amongst United States women, because poverty may lead to HIV. Women who are poor may not have the stable housing and may also have less power to negotiate safer sex and relationships, putting them at an increased risk for intimate partner violence, requiring HIV and other transmitted illnesses. Leadership roles in organizations that empower and support women living with HIV, and two off the top of my head are leading movements, organizations for women to get involved in, is the Positive Women's Network of the United States and the People HIV Living Caucus.
Some other helpful practices for intimate partner violence service providers include adding HIV to the core services you provide for all survivors, including risk reduction, how and where to get tested, and what HIV resources are available locally. You can train all staff to be comfortable and competent when discussing HIV, sex and sexuality, and work in the sex trade. This includes policies about HIV disclosure, medication storage, and confidentiality standards. This is a great place to collaborate with your local HIV and AIDS service organizations. It's important to connect survivors with HIV with community supports. Teresa and I have seen the profound impact that being connected to educational programs as well as networks of women living with HIV has on survivors of intimate partner violence. The more they know about HIV, the more they're able to combat HIV stigma, especially the ways that that's used as a tool of abuse against them. For HIV clinics and service providers, we need to improve health outcomes for women living with HIV by integrating and standardizing routine intimate partner violence screening and counseling in all health and wellness settings. That needs to be a part of HIV healthcare, trauma-informed care. Train and build capacity of all providers, healthcare workers, staff, and peers to have the knowledge and skills to assess and address signs of violence and trauma, and develop mechanisms for clients to meaningfully evaluate and inform service delivery. That includes hiring staff, including management, who reflect the constituency served, integrating mental health services and social support services on site, and partnering with community-based organizations led by women living with HIV. We also need to expand access to safe and affordable housing for women living with HIV with and without children. And individually and organizationally, we hope that folks take a stand against the criminalization of HIV and sex work. As we've said a number of times, laws criminalizing HIV exposure and non-disclosure increase the potential for threats, abuse, coercion, and control in relationships, and may make it harder for women with HIV to leave abusive relationships. We also need to eliminate condoms as evidence laws and other laws criminalizing sex workers and those targeted as sex workers that put them at an increased risk of violence. It's critical that we develop responses to violence against women that do not depend on a sexist, racist, classist, and transphobic criminal legal system that already criminalizes survivors, mothers, sex workers, and women living with HIV. We need to develop holistic strategies for addressing violence that speak to the intersections of all forms of oppression. One of the primary things that requires is centering currently and formerly imprisoned survivors living with HIV in our organizations, leadership, analysis, and service provision. So that is what we have. Here are some resources. We'd love to direct people to the Positive Women's Network and the National Network to End Domestic Violence. Their DV and HIV and AIDS Toolkit has a ton of handouts for both DV service providers as well as HIV service providers. And then the National Online Resource Center on Violence Against Women's Special Collection, Intersections Between Intimate Partner Violence and HIV and AIDS has a really extensive array of information to learn more. So we're ready for questions.
What a great presentation. Thank you so much. And Elizabeth, we were all totally pulling for you when you were having her quickly throw. Oh, I think we were all sorry for you. You did a great job keeping on through that. So I think we've all been there before, so I had a lot of empathy for you. So
Thank you.
Really, really informative. We had one question that I think got answered in the chat box, which we can share, which we will share with you. But so if other people have questions, please type them in the chat box now. You did such a great job covering so much information, and wow, it's sure complicated. I just want to say that I found the 4 I's of oppression at the intersection of HIV and incarceration as a very helpful and powerful framework. So I really appreciate that.
Thanks.
I think that was really great, and I'm just wondering, is that written up somewhere? Because I thought the information that you provided as you were explaining it was really excellent. So I'm just wondering if there's a resource for people.
I'm happy to send my notes.
Okay.
If that would be helpful.
That'd be incredibly helpful.
Okay, and I could also scan a kind of a handout that just talks about the 4 I's generally.
Okay. I think that'd be really helpful. And then we'll post all this stuff up on the Google Docs. And for those of you who are unable to get Google Drive, sorry, I can't keep up with the changes in Microsoft. For those of you who have trouble getting information or unable to access it, just let us know. Just email Dot, and then we'll send it to you directly. So that was really, really helpful to hear about. So very powerful framework. And when you were talking about it, when Teresa was saying, well, if we lived in a world without racism, without all these other oppressions, and it was just like, wow. I think it was just wonderful to have an opportunity to reflect for a minute what that world might look like. So it was interesting just to think about that as you were talking and realizing how far we have to go. But that was just interesting. So great framework.
Thank you, Sarah.
And I also as you, Elizabeth, were talking about the suggestions you had of questions to ask survivors, I also thought that was really helpful. And so if you're willing to share, if you're willing to share your notes, we can kind of maybe together we could clean them up in a way that you feel comfortable sharing them back with people who are on the webinar. Because I thought that was really helpful. So that was great. And so, before you got to that, I was just thinking like, wow, when people were signing in, we just saw that so many people who were on the webinar are from anti-domestic violence or sexual assault programs, and there were state domestic and sexual assault coalitions and national TA providers who were doing training primarily in the anti-domestic violence and sexual assault world. And so while you had some very specific suggestions on what domestic violence programs could do, I was just wondering, like, given this audience, what you were suggesting was basically, talk about it and make sure you're connected to local providers. And it seems like some programs are still not doing that. And so what do you see as the barriers for the programs doing what you suggest? And if, people think, we agree that's the right thing to do, but there's resistance at our program, if you have suggestions on things that people working at programs might be able to do to overcome that resistance, that would be really helpful.
So one suggestion I would tell people that's working at organizations and want to implement what we're talking about into the structural organization that they working at and providing service for people living with HIV is talk about it, have more meetings about it at your staff meetings, express how vital this is, develop some kind of tool model to follow, right, that everybody from direct service up the skill line of those who are in administration can use as a toolbox to help people navigate these very challenging waters of having a safety plan in place when we're talking about trauma-informed care. It's vital that it happens on a higher level. It happens very through and in between, but we need to expand that. And the only way to expand that is to make sure we talk about it in our organizations, build a toolbox that women and providers can use, right? Because initially there is not no real livable toolbox that people and organizations can use. A lot of people are doing it on the basis of just in deciding for the people they serve, but it's not institutionalized throughout the organization. And that's one of the things that we need to do.
Yeah, I think addressing the resistance for me, it would be helpful to have a little bit more information about what's going on in domestic violence organizations, how that resistance is playing out, because Teresa and I are coming from the perspective of working in an HIV and AIDS service organization. But I think maybe something that could help is trainings that recognize what is the common ground, right? And so hopefully things like the presentation that we did today show the ways in which there's overlap, right, between trauma and violence and women acquiring HIV. I think also having folks who are working, having advocates at domestic violence organizations and shelters get trained to be testers so that you have on-site folks who are able to do testing. Having those all-staff trainings, because, I mean, it's really difficult. I mean, there's so much in our culture about not talking about sex, period, and then when you add HIV onto that, there's a lot, most of us have not been brought up in the world to talk about this stuff, right? We need to be trained to do that. And so that needs to be institutionalized on an organizational level, that's part of the training that I think domestic violence service providers are given, and something that's included in assessing who's going to be a good fit for the job. Are they able to have these conversations with people? If they're not comfortable having conversations around reducing risk around sex and drug use, are they going to be able to best serve the women who are the most vulnerable to intimate partner violence and stuff? So that being a consideration, and then as well as like a way of an important part of training people. And then I think like it can't be overstated enough, having those partnerships with HIV and AIDS service providers locally and making that relationship happen and finding a way to create a referral process. So that's what I think of.
Great point. Thanks.
Oh, I think that was really helpful, and I love the idea of including an interview question about degree of comfort in talking about sex and sexuality, and so that was a great suggestion, so thanks. A few of the questions came in about PrEP.
Yes.
Am I saying it right?
Yep, you're saying it right.
Okay. And one of the questions is it available to anyone? And then one of the participants, Teresa, wrote, PrEP is available to anyone, though insurance may not cover it. Some states are focusing efforts to spread information and accessibility about PrEP to those identified as high risk of exposure to HIV. And then she lists the website, the CDC website, that has information. And so then one of the follow-up questions was, can any medical doctor prescribe PrEP to people who are at risk?
And the answer to that is yes. We run into some challenges. If people are not being honest when they're talking to the providers about the risk factors of why they need to be on PrEP, right? And that it needs to be an honest conversation. So you can get access, right? The more that you let that provider know that why is it so important for me to get on PrEP? I'm at high risk for whatever reason, or even if I'm like my partner, what we call sterile couples, where one partner is positive and the other one is not, but they are at childbearing age. And they want to make sure that there's no, because in order to have a baby, you got to not use condoms, right? Even though that one of the partners might be undetectable, but we still need to have another thing on top of that to make sure the negative partner does not transmit require HIV. And another thing about that is making sure that women give birth to negative babies. So the answer to that is yes, but it also is a conversation that you have to have with providers and be honest about what your risk factors are or why you want to get PrEP.
And are there things that activists and advocates can do to kind of make sure that the information is out in that, this whole issue about insurance not covering it? That just seems wrong. But I know there's lots of things wrong with the insurance world. I mean, I assume there's some organizing efforts going on now to make sure it's available to people who need it.
Right.
So I'm just wondering if there's efforts that people could join if they were interested.
So I can only speak to Philadelphia, where I live at, that I have a collaboration with the health department director who is doing a rollout of PrEP, not just for MSM, that's men sleeping with men, but also including women, right? And I work in a service organization where if a person doesn't have insurance, either it be for the HIV medications or even for PrEP, they won't be turned away from services. But what we do here and what we have built over the years is that we have the ability of trained people to get people's insurance turned on. And other organizations need to follow that model.
Okay. And so there's a couple follow-up things here. Tina wrote, PrEP should always be used in combination with other prevention and risk reduction strategies. That makes total sense.
It makes total sense.
Yeah. And then Gretchen wrote, and I'm sorry I don't know this acronym, SPBP help cover the cost?
Oh, so that's special pharmaceutical benefits that a person who's positive can get to offset the co-payments for medication. And that special pharmaceutical benefits when, like, for example, a lot of medications, co-payments are very high. And we want to make sure people, if they get the prescription, that it can get filled, right? So that service will pay for that high-cost co-payment.
Right, but that's for people living with HIV.
It's only for people living with HIV.
It wouldn't work for PrEP then?
No, it wouldn't work for PrEP. Absolutely not. It's just only for people who are positive to offset the cost of co-payments.
So are you aware
of any
program that could help cover the cost of PrEP? And does PrEP tend to be expensive?
I first answered the question that do I know any other programs? The answer to that is no.
Okay.
And any other, if PrEP is expensive, I don't actually know the cost of PrEP, but we will find that out and let you know.
The medical company Gilead has some assistance programs, but PrEP is very expensive.
Right.
Okay. There are some clinics that are helping cover the cost of that, though.
Yeah.
And actually, my coworker Dot asked whether or not SPBP does not my tongue easily. Is that a PA resource or is that a national resource? Do you know?
So special
Gretchen, are you from PA? Sorry.
Okay, good. So you're asking me, is that Pennsylvania Pacific service for the SPPA benefit?
It's Pennsylvania Pacific.
It is. It's only from Pennsylvania.
Okay. Thank you, Gretchen, who is also from Pennsylvania. Okay. So Tina asked, I don't know if anyone else is calling in from Canada, but PrEP is not formally approved in Canada. Oh, gosh.
Oh, wow.
My stereotypes are broken. But it is available as an off-label prescription, and healthcare providers can prescribe it legally. Oops, sorry. Private insurance does cover Truvada. Is that how you say it?
Yes,
Truvada. Government plans. So
yes.
That's interesting. Huh. Very interesting. So then it's this talking about, Sharon is also writing about a program that does assist eligible HIV-negative adults in the U.S. who do not have insurance, that you can get, there's an assistance program. And she gives
so that's the AIDS Drug Assistance Program. That's the national. SPBP is what Pennsylvania calls that.
Right.
Got it.
The AIDS Drug Association program is national, and the short term for that is called ADAP.
Okay.
The people that like ADAT. We have certain states that don't have ADAT, but majority of states are and getting on board to make sure they have ADAT services.
So this is a Truvada medication assistance program that Sharon listed, and so there's information about that and a phone number to call to see if one would be eligible. So thank you for sharing that information. It's very, very, very helpful.
Just a correction that all states do have it, the ADAT program, but they have a lot of people on a waiting list, which is also a barrier.
Okay, so that's another
and a challenge.
All right. Very helpful. And, I just have to say that it was just interesting working with the two of you on this webinar and just realizing that even though I kind of think, I'm kind of up on things, how much of this stuff I don't know, and that the acronyms are different, and that I don't know the language. And so it was a very educational process for me, and I hope it was for the people who were on this webinar as well. I mean, part of what I learned is how much I don't know. And so I just really appreciate you taking the time to bring us through some of the very most basic information that is so important for all of us to have. And I thought you just did a great job tying that basic information into a very complex framework, and I just think it was really great. So I just really want to thank you. And I'm just going to turn it back over to the two of you to see. We don't have any more questions at this point. I hope I caught everybody's. I think I did. And so I'm just wondering if the two of you have some final words for us.
Yeah.
We go out into the warm weather of Philadelphia in November.
Yeah.
I know, it's just crazy.
I think Teresa has some final recommendations.
I do. So I have some recommendations from the Positive Women's Network. They are solutions and recommendations. One is bold leadership to address violence against women living with HIV on a federal level. 2, the Office of National AIDS and Infectious Disease Policy must amend the National HIV Strategy to include objectives that integrate and prioritize trauma recovery, violence prevention, and sexual and reproductive health services with HIV care for women. 3, repeal all laws that criminalize HIV and provide a sensitive training to law enforcement officers, providers, healthcare workers, violence specialists, and child protective services. And finally, invest in the workforce development of women living with HIV by creating leadership pipelines in the HIV-focused organizations, and work with the Disability Act to protect the employment rights for people women living with HIV, and promote public and private sectors back to work job training programs for women living with HIV, reentering back into the community after incarceration. And that is my final statement and my recommendations from the Positive Women's Network.
And thank you all for sharing a bit of your afternoon. Please reach out to us with any further questions. Our contact information is on the screen and on all those slides. And we hope that you'll be joining us in working to better serve formerly incarcerated survivors living with HIV.
Yes,
have a wonderful afternoon.
Yes,
thank you so very much, and thanks to all. And we'll try to get as much of that information up on the Google Drive as we can. So we want those recommendations, Teresa, as well. So
okay, I'll send them to you.
That was a lot at the end, so I really like to be able to put those up. Okay?
Sure.
Thank you so much. Have a good afternoon,
Thanks,
everyone.
Sue. All right, bye-bye.
Bye-bye, everyone.
The short questionnaire, please. It's really helpful to us and to the presenters. Thank you all very much. Have a great afternoon. Bye.
You too. Enjoy your afternoon.